So, yeah, why is my dermatome? Can I steal your dermatome there? Somehow mine's missing. Okay.
You're welcome.
Okay, so the things that you do need to know from this though is make sure you are starting to get a basic understanding of the brachial plexus. I know you guys haven't really studied this yet.
Yeah, we did.
Oh, you guys did?
Yeah.
Yeah, one in Benicio.
Oh,
We had to know all of
so you
it.
guys had to memorize it?
Yeah.
I thought you guys didn't memorize it until 210. So, anyways.
I can draw it for you right now. Memorize it now.
Okay,
Probably draw
so
it too,
just
actually.
refresh that, okay? Because there will sometimes be just like a few questions on that. So just make sure that you're kind of refreshing on it, okay? And I'm not actually going to go into this all that in depth because this is actually lame compared to what you guys have done. Then just remember you've got your roots. They all start right here, right out of the neck. That's your roots. Then coming out of that, each of those roots breaks into several trunks, and then those trunks break into cords, and those cords break into branches, and they literally run all the way down your arm and into your back and other places too. So just kind of know that. And just, yeah, if you already know it, awesome. And just know there might possibly be some questions over that. The other thing, and you guys must have learned dermatomes too then? No, okay.
210.
So this is 210, and I'm right about something, at least. So, in kind of conjunction with your brachial plexus, okay, the brachial plexus is just where nerves are coming out and down to your body. What type of nerves are those?
I
What's he say?
Efferent.
Afferent is away. Right?
Efferent.
No.
Efferent.
Oh gosh.
Right, okay. Efferent goes down,
Okay.
afferent goes up, right? Is that correct? Okay. So efferent goes down, afferent goes up. So your brachial plexus are those efferent nerves. They're what leaves here and actually kind of the front of your spine a little bit, or laterally kind of to the side, comes down and sends the signals to your muscles to contract. Well, you have like a mirror opposite of that in your body that is touch receptors and sense receptors, and they go back up and send signals to your brain that lets you know something's on your skin, or you're being poked, or there's some type of pain sensation coming in, right? So that's what dermatomes are, and this will really come in more in 210, but I just want you to understand the concept to start. So your skin is divided up into these areas, okay? So anything in your head is C2. So all those nerves, sensory nerves, those afferent nerves in your head go down through C2 and attach to your brain there, okay? And then C3 literally just kind of runs down here along your neck, as do C4, as does C4 just a little bit further down. So this just covers right here, C3 basically, and this just covers C4 basically. But C5 gets into further along, and that'll become important because C5 runs down your lateral shoulder and your deltoid and kind of comes down here, and it actually controls your biceps reflex. And you can kind of see it if you pull this picture up. See, C5 starts here, runs kind of basically at the top of your sternum, across the shoulder, down your shoulder, and just along this part of your arm to basically right here. Okay, so if you touch somebody in here, or you're giving, and you'll get there in 210 where you do biceps, just like you do quad reflex, okay? But you can do the same thing with biceps, get them to contract their bicep. All of that's caused by that C5 receptor. C6 runs lateral, the lateral arm, the thumb, the brachioradialis reflex, and you can kind of see the picture here of what C6 does. Okay, so C6 actually only starts on the lateral arm and then literally runs just on the very, very outside of the arm and down through your thumb. Okay, C7 also is basically just only in your arm, and if you can kind of see on the back, well, it kind of comes down your back and then runs down the back of your arm, and then basically these two fingers, okay? And then C8 obviously starts in your back, runs down the medial part of your arm, and then down into your ring and pinky fingers. And then final one is T1, and that is just kind of your chest. And so you just need to kind of know and understand those, because if patients are having sensory problems, where they're not feeling touch or something like that, you know where the damage might be in their spinal column. It works the same way with the brachial plexus though. If they're only able to do certain movements, and this will really come into play later in 210, then you know, like, if somebody has a spinal cord injury and they can do this, but they can't do this, or whatever, then you're able to know, okay, I know what part is damaged and where they're damaged at. And so that's where dermatomes really kind of become important. Really, this will kick in more in 210, but they just want to kind of introduce the concept here that not only do you have nerves that come out, you have nerves that go back up, and depending on what part of the body, you know which nerve it is. Make sense?
And they are sensory nerves.
They are sensory nerves. Sensory and pain.
So should T1 be included in this upper extremity?
No, not really.
Okay.
It does affect, like T1 actually does go down into the hand and arms though, and will come into play later. That's the only reason I brought it up. And so if you see in the picture here, there's a whole map of just which, kind of generally which control which parts. Thank you. You're welcome. I use that, and you're welcome. So anyways, those are the only things though that are actually super, oh, there it is. I just remembered. Yours was in color though, so. That's really the only thing in chapter 7 or 8 that either we haven't covered, because it will get into, at the end of chapter 8, it starts talking about rhythmic initiation, alternating isometrics, rhythmic stabilization, slow reversals, and agonist reversals, but we really covered those pretty well. If you have any questions, always feel free to text me. I might make a joke out of it now, but I will answer, okay?
You do answer.
And I don't mind at all, but I just don't want to waste, like, time on stuff that we've already covered.
So we just need
And
everything.
the rest of the notes are literally just like, this is an injury you can get. Okay, thanks. So, alright. So my one that I was left with was a proximal humerus fracture. I already kind of made out my sheet for it, and I'll pass those out. Actually, just kind of circulate them around. Okay? So a proximal humerus fracture is basically exactly what it sounds like. You can get humerus fractures anywhere, but the most common place, and the reason I picked proximal for us, is because most of them, if people get a humerus fracture, are in the upper arm. Okay, they're in the upper shoulder. One of the most common ones that I saw over and over and over is an intertrochanteric fracture, and it's just where between the greater and lesser trochanter, so you've got the shoulder up here, kind of like
Tubercles?
so, right, and that's not actually very good, that's not for that, and it comes down, you get these fractures that kind of go like here or sometimes here, and those are all called intertrochanteric fractures. Okay, because they're just in between the no, that's tib. I'm sorry. Jeez. I'm confusing the hip. But intertubercular fractures, intertrochanteric is hip. And so, anyways, I drew it looked like the hip when I was talking about the hip too. But anyways, intertubercular fractures. Okay. And they can be kind of up here too. There's all different causes, but mostly they're from falls. People, when they fall, have a tendency to want to put their arm out and to try and protect themselves. You actually shouldn't do that, just so you know. If you do fall, you're supposed to kind of just hug yourself and take it, okay? Although there are problems with that too. Well, so anyways, just real quick, and I'm not, but when I first learned how to snowboard, okay, they were like, don't ever put your hand out when you fall, right? And so I was like, I won't put my hand out. So towards the end of the day, it had been kind of hot, starting to get a little bit of ice on top because it melts, and then as it gets cold again towards the end of the day, you get freezing on top. So I'm trying to kind of turn, and it's so slick that my board is just not grabbing, to turn. And so I'm like, I'm going down. I can feel I'm going down, and so I was like, okay, I'm gonna do exactly what they said. Come down, and I land just literally on my hand. Hit so hard into my clavicle that it literally popped my 2 ribs right here. So I don't know. But anyways, it's kind of like, I don't know. But anyways, you don't want to put your hand out. The one time I did put out my hand, broke my hand. So 6 of 1, half dozen of the other, I guess. But this is most of the fractures are kind of up here, more towards the shoulder and in the top of the humerus. That's just more commonly where they are. They mostly are surgically repaired. It just depends on if it's a full. If it goes all the way through, they're almost certainly going to surgically repair it with an open reduction internal fixation, where they come in and they just put like screws up through here and into the ball of the shoulder. Or if it's lower here, they'll put a plate, or maybe 2 plates depending, and put screws in through there to just hold the bone in place. Okay? So just kind of understand what's going on there. So, how do we deal with that if somebody gets it? The first thing you need to know is, until the bone is fully healed, the big contraindications with this one are no forced or aggressive stretching until the fracture is fully healed. Really, you're not doing any stretching at all. Not until the doctor releases them to do stretches. Usually it's 6 to 8 weeks. Okay, but definitely not before the doctor releases them to do that, because you can pop that bone back loose. Okay, and so you definitely don't want to do that to somebody, so you want to wait until it is healed over. Once it is fully healed, though, you're good to go. In fact, bones normally actually heal stronger than before they broke. So the other thing is in the first phase, and there'll be other things I kind of hit on, you don't really want to do active range of motion, but that's really true of almost anything. In that first phase, you're mostly not doing active range of motion. So, what would we do if we saw somebody in the first phase? First thing we're going to do is we're going to control pain and edema, right? So we're going to rice them. If we're doing pain treatment, we're going to basically make it ice. They're going to put them in a sling. They're going to stay in a sling probably for 4 to 6 weeks before they start even getting out of it at all. And so you're going to kind of even educate them. One of the things you're going to do is how to hold it in that sling and just educate them on how important it is to keep their arm in that sling. Okay? Because it's going to, if they just let their arm hang down, gravity pulls on it and you start to get separation in that bone. So they really need to make sure they're staying in the position that doesn't allow gravity to really pull and the sling prevents that. Okay? So, what do we do to help them? Well, the first thing is, and I'll need a volunteer. Okay. All right. Just stay for me. So I would, hang on, I'm going to steal your chair that you were sitting in. So let's say she broke her left femur here, okay? So she'll come to me, she's in a sling. I would help her gently get out of the sling, okay? And we would just start working on range of motion with the hand, okay? Range of motion with the digits first, and then the fingers, and then the wrist, okay? And then even the elbow, okay? Here. And then the other thing we would have them do for range of motion is cervical range of motion. So I might have them do cervical flexion and extension, lateral, side bending, rotation, and then maybe overall just some good, slow neck circle. Why am I doing that?
Because you're stretching everything above and below the...
Right. Because this patient is having to stay still at the shoulder at least for a while. And so for the first week or two, you might not be able to do anything, or even possibly longer, just know that. This is where you'll always be able to do the joints around it, maybe not necessarily strengthening, but at least range of motion, okay? This is where the, this is where the surgeon's recommendations or the orthopedic doctor's recommendations really come in. Some of them will want them to not do anything with that shoulder at all for 6 to 8 weeks. Okay? Some of them after 2 or 3 weeks will go, okay, I want you to start doing some really light passive range of motion. It just kind of depends on how bad the break was, how extensive the surgery was, how cautious the surgeon is. And so you don't really know for sure. If you do start doing, if they do allow you to do passive range of motion in the shoulder as well, after, usually it's a week or two if they do start letting you do it. The best way to do that is with, so I'll have you come back to my phase 1 patient autograph. So what I want you to do, Ray, is I want you to come in here and just remember, so I would have her just take out of the sling, okay? And so I'm just going to take this out of the sling. And so what I want you to do is I want you to lean forward for me and try and kind of keep your trunk perpendicular to the ground, where you're almost kind of flat. And so I want you to just let your arm hang for me. So what I want you to do, and we have to be really careful here, is I don't want you to move this arm at all. I want you to move your body, okay? So go ahead and stand up just for a second. I want you to see it, and then we'll do it, okay? So you want to have that arm down. You can go back and forward, moving your body, letting your arm swing back and forward. You can go side to side, okay? And you're really moving your legs here and your body. And then you can also go circles, where you use this other arm and your legs and your body to go circles, and then you can go the other direction too, okay? So what I want you to do first is I want you to just go ahead and come forward. So you always want to explain it, then you want to show it, then you want to have them do it, okay? It's called a return demonstration. So you say it, you do it, and then you have them do it with anything in therapy, okay? All right, so I want you to try and just do back and forth for me. Good. Kind of relax that arm and let it swing a little bit. Just think of a big floppy elephant trunk, okay? Good. Now let's try side to side. So just kind of let that arm swing side to side. Okay, try to relax. See how she's holding it super tight? Okay, so you kind of have to, and you can't really pull on it, but you can kind of go, okay, think about getting floppy, okay? And then let's try a circle. There, it's a little bit. Now it's pulling a little bit. It's going a little bit. Okay, good. So that's one of the best passive range of motion exercises you can do with the shoulder, period. Another one, and I'll have you come over here, is called a counter walk away. Okay, so what I want you to do is with this arm, and I'm gonna have to move some stuff. I want you to put your hand on here, and I want you to make sure you're holding the hand through there, but don't really put like tons of weight through it because you're not ready to bear weight. Just put your hand on it. So what I want you to do is just kind of back away, okay, and slowly. And you would only do that to the point that they don't have any pain, okay? But it's just a way to get the motion in that shoulder without them having to. What muscles are you moving here? It's all in your body and your legs, right? As you extend. So let's try. Good. And then you can kind of just come forward. You can also have them do it out, but it's a little awkward and strange. So I would basically just use that for flexion and extension.
Is that essentially passive range of motion exercise?
It is almost like self-passive range of motion, yeah. So those are the big ones. Go ahead and sit just for a second. I want to make sure I'm not missing anything. And then, like I said, you're educating the patient on what they can and cannot do, making sure that they're not bearing weight through that arm, make sure that they're not moving that shoulder at all on their own, and you're educating on them on why that's important. The best way to do that is just tell them, if you move that arm, it's going to heal slower, you're going to be in the sling longer, you might even have to go back and have surgery again. So you really want to be extra careful to follow those surgeon's precautions of keeping your arm here, okay? Make sure you're keeping it in that sling. Make sure you're not moving it on your own at all because those muscles will fire and it'll put pressure on that bone. It won't allow it to set and heal. So make sure you're not doing that. And then, like I said, we're no active range of motion, no stretching, no strengthening. The other thing you can do though, that is actually the only resistive exercise you can do is you can have them start doing some gripping exercises with that hand. You want to make sure whatever it is, it's really light because you don't want to put a weight in their hand that's going to pull down on that fracture. Make sense? Okay. So let's just try and squeeze that. Okay. You can use a ball, a tennis ball, a clay putty. Lots of clinics have putty, but you just, or they have these neat things too, where you just have them squeeze. This one is designed where you can do each finger as well, so you might have her go through all of it. Okay? All right. I need somebody new. So phase 2. Okay, this is going to be in, depending on your surgeon, the 4 to 6, maybe 6 to 8 week range. Okay, they've just gotten out of the sling and they're actually to the point where they're healed and you're starting to be able to do so. Okay? So, go ahead and sit. So we're going to say it's the left arm still. Okay? So what you can start doing with them is any range of motion exercises. So I might have her, Katie, so what I want you to do is I want you to just lift your arm up as far as you can. Say she's not able to go all the way, I might passively active assistively, I want you to help me, and we might go a little bit further. You might start doing, so active and active assistive range of motion both. And so you would just go through all the range of motion and just kind of help her. So I want you to just kind of go in and out like this. Okay. So you would just run through all the range of motion with them. They can do it against gravity for strengthening, but they're not quite probably ready for any other stuff. You will start weaning them, and I'm sorry, that looks like wear more than wean, but you'll start weaning them from the sling. They've been in that position for so long, they may not be ready to just like let it go, but say, if they've been in it 24 hours a day, except for when they're sleeping, start telling them, I want you to take it off for an hour, okay? And just walk around for an hour with it out so that you start getting used to gravity pulling on it. And I'm going to show you just a few exercises that you can start doing with them. So active assistive range of motion exercises, wand exercises, okay? So, Katie, what I want you to do is I want you to take your hand and turn it over. Good. And this one, turn it over. So the key is always make them have their thumbs facing in towards their body with any exercise that you do with them, except some specific ones later on. But in general, you want their thumbs facing in. Even as they do stuff up here, you want thumbs coming towards the body. Does that make sense? So I want you to use this arm and hold on to this. Bring your arms out straight, and I want you to kind of lift up. This arm will be weak. Won't be able to do the action all on its own, but you're using this arm to help lift it up and assist. Okay? It is active assistive. Now, here's the thing with that. It's one of those things that I'm kind of, apparently there's debate among PTs. Like if you go online, I watched one from Dr. Joe yesterday, and she was like, you can do this as passive range of motion too. Other PTs will say in the book, I believe said, it's really hard to not get them to fire muscles while they're doing it. Okay? And so a wand exercise, you can do flexion, you can do internal and external rotation. Okay? And you can even do, so I want you to kind of straighten your arm out now. And you can do abduction and come across, and then it's adduction as well of the shoulder, right? So you can pretty much get all of the different exercises through that just by using a wand, okay? You can use a broomstick, you can use that. Anyways, moving on, I don't want to take too long. So, just so you guys can see, and I'm just going to run through this one really quick, you can have them do the same thing with pulleys, where you have the patient sit or stand, okay? And you start having them do this, reflection and extension, okay? This is one of those ones that, depending on what your PT says, you can try and have them do it passively, but it's really hard not to have them fire the muscles, okay? You can also do, you can do abduction as well, though, okay? And get them into that. And if they're slow and careful, it will also do adduction. There are even ways to have them do internal and external rotation with those, but it's kind of hard, and I actually wouldn't. If you want to do, so anyways, those are some of the big ones. Let me see if there's any ones I put on there. So you can also have them start doing PNF with the wand, just so you know. Start thinking of kind of rotational patterns. So it would be kind of go up here and then come back down, and use that to kind of help you where you're starting to get some of that rotational activity back in. And finally, a really good one for this stage are saw. They call them saws, where you're just having them come back and forth like this, like they're sawing. So you're starting to get the scapula kind of involved on that one. All right, who's next? Oh, I want to show you guys one more. because here you can start doing isometric strengthening at this phase, and this one you might have to kind of come over here where you can all see. So the shoulder, you okay there? The shoulder does 6 different actions, okay? Flexion, extension, internal rotation, external rotation, adduction, and abduction, and technically there are 2 others in horizontal, but the big 6 are those, okay? You can have a patient do isometric 6 ways, and you can also have a patient do resisted or active range of motion 6 ways. So for flexion, you have the patient stand with their arm right by their side, put the ball here, and they're going to try and flex that elbow forward. So they push, 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 push for 10 seconds. Relax, and you do like 2 or 3 sets of that. So extension would be just the opposite. Hold the ball here, try and extend your shoulder, extend, 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 extend. Okay, so that's flexion and extension. You can do external rotation, ball here, okay, and you try and turn your arm out, pull, 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 pull. You guys see that over here? So it would be this way, okay? So they're right here and they're just pushing out against it. Then you would do the opposite. For internal rotation, go here, turn in, and then abduction is push out, 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 out. Adduction is kind of here, here, here. Okay?
Why do you use a ball?
I don't know, it gives them a little bit of something to kind of just push against, and it helps them think about it a little more clearly. You don't actually have to use a ball. I just kind of like that it gives them something to think. I'm trying to push the ball. And so it's a little bit, yeah, it's a little bit psychological almost, and it's not as hard for them to realize, because you don't want them stretching really necessarily yet. And so it's really easy for somebody to get up against a wall and start going, oh, no, I want you to keep, and so the ball kind of helps that. All right, and phase 3 is where you're going to really start increasing strength. So you would do your scapular stabilization exercises that we went over last week, okay? Where you have them, and I need a new patient, I guess, real quick. Oh, it's good. Yeah, just lay down right here. So remember those. You can have them put their shoulder, and it was the left arm. We'll keep consistent, okay? So what I'm going to do, Caleb, is I'm just going to kind of push against your arm, and I want you to resist me, okay? Don't let me move, okay? So here, 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 and then I'm just going to start randomly doing it, and I want you to prevent me from moving your arm, okay? You can go in all kinds of directions. This is to stabilize the scapula and get those muscles that have gotten weak, serratus anterior and the rhomboid strong again. Okay, up. You can do your PNF stretches now. So you would start stretching them. I'm not going to actually stretch you, but just with any of them, okay, if he's having a hard time flexing, I might go, okay, I want you to flex against my hand, flex, 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 or hold, relax, and then I would move him into more range of motion, right? Just to try, and you can do that with any action. This is where you can start using the wands and the pulleys again, but for stretching this time. So I would have him come over here. Go ahead and come over. And so what I want you to do, Caleb, since you're having trouble with flexing your shoulder, is I want you to, this left shoulder, I want you to bring it up as far as you can, and you might have to shorten this a little bit. And then once you get to that full range of motion, I want you to pull it back a little bit more, and I want you to hold it for 15 or 30 seconds, okay? Yep. So So you can shorten it. And what you can do, just so you know, on these are pulleys. This one's kind of messed up. You can take it and tie a knot to where it's further down and it shortens it to where it'll allow it to stretch it a bit more. Okay? So, and you would just hold it as long as you could for 15 or 30 seconds, relax, and then you could do that again. So it's almost kind of a mechanical stretch a little bit. You can do the same thing with like the water, just so you know. Have them stand, and if they're having like bad external rotation, I want you to push it into that external rotation, and I want you to hold it. Okay? So I want you to try that. Make sense? And then they would just hold it. You can do the same thing though. Internal rotation is a little bit tougher because you need the bodies in the way, but there are just ways you can use the wands and stuff to do that. Okay? You're good. Scaption, if you're having trouble with the scapula, you can start doing scaption exercises, okay? Thumb up, pointed towards you. These will focus a little bit on the scapula and help them stabilize the scapula. And then, obviously, rows, and then 6 ways, okay? You can do 6 ways with bands, too. Obviously, you can do it with other stuff, but what you can do is tie a knot in it. Come back over here, Caleb. Oops. And this can be your thing. So the first one we're going to do, Caleb, is I want you to flex your arm up and bring it up for me, and then bring it down. If you can go even further up, that's even better, okay? So left arm. Good. And so it's the same thing. Good. You just have them go through it nice and slow. I want you to control it on the way down. Good. Okay. So you can run them through all of them. So we just did flexion. You can do extension as well. You can do internal rotation. You can do external rotation, right? And then you can do abduction, and you can do the other way, adduction, right? Okay, so you can get all 6 range of motions just by taking that and closing the door. Good. So I think that pretty much covers it. Innies and outies are just having them lay on their side and do internal and external rotation. The rotator cuff is what ends up getting weakest, and it's the first thing you really want to work on strengthening because it stabilizes that joint, right? And so to prevent them from getting like shoulder dislocation and stuff, you really want to focus a lot on internal and external rotation exercises to strengthen that capsule and strengthen the muscles that hold that shoulder still. And just the last little bit of stuff. So you would send them home with self-stretches, okay, for all range of motion. Just so you know, I'll run you through a couple of cool stretches. So you can have them at like a table at home. Oh, it's 1 foot. So anyways, you just raise it and you have them slide their body forward, right, and then hold it for a flexion stretch. For external rotators, you can do a very similar thing. Arm up here, they would be higher, and they lean into it, right, to where it's getting a stretch on that. So anyways, ab and adduction work the same way. Abduction you can do anyways, have them just kind of slide it out on the table and then kind of push into it. Adduction's a little, you can't really do it. But those are good for the main 3. And I don't want to go too far. Wall crawls, okay, where you have the patient put their hand on and just kind of slowly crawl up the wall to where they're getting more flexion. And then If they want to stretch it, they just lean into it when they've hit that as high as they can go. Works for abduction as well. Here, 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 crawl up the wall, get to where you can't go anymore. Now I want you to kind of lean into it a little bit and stretch it. Okay. And then you can send them home with bands for 6 ways. The main thing you want to make sure is that they're not compensating their range of motion, right? So they're not trying to flex or extend or whatever the rest of their body. Make sure they're just focusing on the shoulder. Innies and outies they can do with a soup can.
What does the number in parentheses mean?
So this is like the different phases they're at. Okay, so self stretches are going to be phase 3, 6 ways with resistance, TheraBand, TB, 6 ways or phase 3. Wall crawls are going to be phase 3 because there's going to be stretching involved in that for flexion and abduction. Passive range of motion, a family member could start doing with them at the end of phase 1, possibly maybe phase 2. You would just have to educate them on that. Towel stretch, that's the only one I didn't really go over. So the affected arm, have them take a towel, flip it behind their back, and then they can just kind of reach it. And if they're having a hard time with external rotation, no, internal rotation, you'll pull up like this, and it'll force that shoulder into an internal rotation. Okay? You just hold it. So, I probably took way too long, sorry. But I just wanted to kind of cover several different ones so that you guys had a good idea of a lot of different exercises. So, if you had a shoulder one, which a lot of you do, I may have done some of the ones that you're going to do, that's okay. It'll allow you to go through it a little bit quicker, but it'll also allow us all to see those exercises again and have them kind of stick in your mind. Okay? Any questions? Feel fairly comfortable with it? Okay, all right. So, I guess Alex is up. So you can use the overhead thing if you want, you don't have to. That's okay.
Scapular winging is just the separation of the medial border from the posterior rib cage, so it just goes out more than it should. Usually the causes are paralysis of the nerve or just weakness of the muscles in general. So the main muscle is the serratus anterior. The muscles also involved are the rhomboids and the middle traps. So if there is paralysis involved, the nerve damage will be in the long thoracic nerve, dorsoscapular nerve, or the spinal accessory nerve. And if it's really serious, then that's when they will consider surgery. It usually just occurs because a person has like a job where their hand is constantly overhead, or they're throwing like baseballs, they're trimming bushes, or they're swimming. And what can cause is just the weakness of the serratus anterior muscle and the tightness of the pec minor muscle. So for a physical therapist, you'll just address strengthening the serratus anterior and stretching the pec minor muscle. So you can easily see it with patients when their shoulders are rounded, or you just see weakness, decreased range of motion in the shoulder, difficulty raising their arms overhead. And you can tell, they'll say when they lay on their back and you kind of raise their arm, it'll be painful because the shoulder blade will dig into the table or bed. So like I said, lengthening. So yeah, for physical therapy, we can massage the pec minor, or you can So they're laying on their backs, supine, and their hand is overhead. They can hold a rod if they want, they can use both hands if they need to. And then the therapist will just be moving the arm in various directions, and just let them know to resist what motion you're providing them. So, yeah, so I just put the mix of there was really no protocols.
Right. And some of them you guys will have found, and I'm glad you guys did. Some of them don't have stage 1, stage 2, stage 3 because they're not technically injuries, so to speak. They're muscle imbalance and weakness. So you can immediately start strengthening and stretching and things like that.
And then, once you see that they're getting stronger and they're able to stabilize the shoulder a little better, you can go to closed chain exercises, which is just putting weight through the arms, through the scapula. So you'll start with static, so you'll have the patient, hands on the.
So let's have somebody volunteer. I want you to demonstrate.
Okay. Let's volunteer. So, yeah, you can put your hands on the wall like this, and you're just going to push it in this direction, and you're just trying to hold your position. Okay, so you can go side to side, backward, like that, and then if they're able to do it, then you can have them put their hands on the ball. So so you can have them put their hands on the ball, put weight through the arm, and then you'll be pushing the body side to side. And you can stretch perfectly. And then a way to progress it, the patient can go on their hands and knees, and then same idea, you're pushing them back and forth.
So do you understand what she's talking about, hands and knees? You would have them get on the mat and hands and knees, and then you're pushing them all different directions. The mat is really good because it allows you to push a little bit more in several different directions. Okay?
And then once they're able to do that, there's rocker boards or wobble boards.
Oh, we actually
Or
do.
Bosu ball.
Yeah, we have. I'll grab one. I didn't think to get those out, but we have. Which do you want? Motion ball, rock ball?
All of them.
Yes. Allergy medicine. This was not a good day to have only lecture.
So you'll just have the patient on all fours. They're just gonna try to keep their balance on the board, and they're gonna have them remember to keep their shoulders like protracted like that. And then you can move them side to side, and they just have to maintain their balance.
Do you move the patient or the board?
I don't think it matters. Like you can move the patient over. Probably the patient.
Well, and the board will kind of move some. The point is that you're trying to get them to move that scapula in both directions. So either one can actually work. One is more stabilizing. The other one is a bit more strengthening. If you think about it, if you're having them have to try to hold it and you're moving them, then it's more stabilization. If you're moving it back and forth, then you're getting more into strengthening those different scapular muscles.
Yeah, and then the last one was just dynamic, so the patient themselves is moving themselves, so yeah, I guess we can go back to the wall. So now the patient will actually keep their shoulders protracted, they will weight shift from one extremity, the upper extremity to the other. So they'll kind of like go back and forth like this. Full body weight on it, yeah. And then the progression is still the same. You add a ball, and then it says, lift one hand off the wall as well. You can just feel like a lot of body weight over the. board, or the Bosu ball where you flip it upside down. And then the Bosu ball, I feel like would be more of a challenge because you can go like in all directions.
Do you guys know what a Bosu ball is? Okay, let's grab one.
Follow like this.
Because this is actually a really good exercise. I want you to demonstrate if you don't mind.
Yeah, you can probably go back and forth.
So this is a Bosu ball, okay? It's called Bosu because it's both sides up, is what that stands for. So you can use it two different ways. You can use it, which she's about to use it, is this way, okay, and do stuff like this for balancing, or you can flip it over, have people stand up on it or try and do push-ups or all different kinds of things on it. I've got a really good video in my office from Bosu itself. You guys can check out sometime if you want. That goes through just tons of different stuff. Bosu is a great thing. So, okay, yeah, if you don't mind just showing us that one.
So yeah, you'll flip it upside down when it's not stable. You can go up onto all fours, or if they're not able to, they can just stand with the table lowered. Hands side to side, and then they themselves can just go back and forward, front, back, or in circles. Just to strengthen the serratus anterior muscle. And yeah, that was the last one. So to go home, you can teach patients what a scapular push-up. So what that basically is, instead of a regular push-up, they're just moving their shoulders back and forth like this. To add weight, you just do it against a wall.
Good, so to start out, okay, they're just doing it up here. That's the easiest version. And then up against the wall, so you're adding weight progression.
And then banded shoulder protraction, so you would teach them this one. So just adding resistance, so it's the same concept. This. Wall slides, you'll have a patient put their forearms on the wall, and then you'll just have them kind of go up and go back down. Still keeping the shoulder blades protracted.
Yeah, so make sure they're still kind of keeping them squeezed as they do it. Okay, so that they're holding that shoulder blade in against the body as they slide it up and down.
Are they bearing weight against the wall?
Yeah.
While they're doing that?
And then lying dumbbell shoulder protraction. I think it was just kind of, because usually if, they're not having a lot of difficulty laying on their back anymore, but you'll just lay on the back and then it'll be that same motion going up, but just with weight added. Does that make sense? Yeah.
Like a serratus punch.
Yes.
Yes, basically, yeah.
Yeah.
A serratus punch and then bringing it back down. Really good to emphasize with this, the eccentric, push up and then really slowly come back down as you retract that scapula.
And lastly, you'll just teach them how to stretch the pecs. So you can teach them the doorway stretch, the open door stretch, if you learn. You just walk into the doorway and then gently lean forward. Or you can add a massage ball, and you can just put the massage ball right where they have tightness, and then they can go against the wall and kind of just like use your body weight to stretch that pec minor. Yeah. And that's it. Anything else? Any questions?
Good job. Good job, right? Yeah. So that's all we're kind of looking for is just kind of go. And the cool thing with this one is obviously there weren't phases, and I will copy this and get a copy to everybody. But you're strengthening what's weak and you're stretching what's tight, really. So one thing you would want to do is not just teach them at home stretches, but also stretch them. You would definitely stretch pec minor, but also pec major too, because it's the whole rounded shoulder thing. But you're right, pec minor is kind of pulling down that scapula and pushing it out. And pec minor is the one that attaches to the scapula. And so the way you do focus on that is maybe putting a ball just right on the area and leaning into that. So, and there are other pec minor stretches too, but I just want you guys to understand the concept. No questions? Good job, Alex. That was great. Good job. All right, so up next, acromioplasty or subacromial decompression. Let me get these things out.
We should have done ours together.
Seriously,
I-
mine goes like merges into yours.
I know. I said we should have done ours together.
Right, and they can be similar, and I don't even mind if you guys kind of want to pair up and like, some of them will be very similar, the treatments will be very similar. That's okay. It really is okay. Because you'll start to kind of see an overall pattern on how to treat the shoulder and how to approach things. So.
I know, mine's kind of messy.
Mine's like almost exactly the same thing.
Okay, so shoulder arthroscopy is usually what's done because you have subacromial decompression, and there was different types of the acromion of the scapula that there was 3 different types that I had. So Marcus, where's Marcus? Oh, there's Marcus. So you had
You can erase my here.
your humorous,
Very humorous.
very humorous.
Yes, I am.
So, there was a type 1, which was just pretty much a straight, right? Am I getting that right? There was type 2, and it was kind of curved, and then the type 3, and it was more of a hook. If that makes sense. Does that make sense with the acromion? Right? Do I have it backwards?
I think you're right.
Type 1, type 2, more of a slant, and then type 3 were.
So what she's talking about is what's going on there in the acromion that's causing the impingement of the supraspinatus tendon, right? And so there are different shapes, and some of them are more hooked, some of them it's because the acromion's kind of weird and rounded, and some of them it's because it's actually too straight. And so they'll go in and surgically fix it no matter what type. And so that doesn't matter like too much. You just need to understand what the concept overall is.
So I guess the type 3 was the one that kind of dug in and cut off and started digging at that supra, which led to rotator cuff tears, which Brett will talk
It
about
does.
in a minute. But the contraindications were, for phase 1, was to avoid activities that may impinge on the acromion. So that was anything like elevation and horizontal adduction. And also patients after surgery use a sling, or before surgery they use a sling, just to not further the damage. And I didn't find this in there, but I know people that have had this done, and they've been in a sling, and then they did like a pre-rehab before, like a strengthening. Where
They will sometimes do before surgeries or even before rehab. They might send patients into PT prior just to kind of strengthen the muscles around everything to get them ready for the surgery. That way the surgery doesn't take as long to recover from.
So for phase 2, same thing, just avoid repetitive overhead activities. And these are my contraindications, and then I'll go into the phases. Post-rehab soreness should alleviate within 12 hours of the activities. And so if they last like 24 hours, then they're probably way too intense for them to recover from to go into a next treatment. And same thing with phase 3. I'm not sure if that's what you were asking for in the contraindications.
Well, it's okay. Some of them don't have very much. Like this is more of like just inflammation and an injury. So you're going to be resting the area. You're obviously not going to want to probably do much active range of motion too much, right? Initially, And so you just want to kind of think about those overall concepts. And it'll actually get, if you like pay attention to what they're doing in phase 1, you'll know kind of what the contraindications are, because you're like, well, they're not doing any strengthening. Why is that? Because it's contraindicated.
Okay, so for phase 1, which is surgery till about 3 weeks, the treatment involved cryo, obviously, for the swelling and inflammation. They begin treatment 7 days post-surgery. Isometrics for internal rotation and external rotation, so same thing like what we talked about. Like, it was almost the same exact, like everything you went over was like pretty much everything that I'm sure everybody that had shoulder and would use. So, flexion, extension, abduction, shoulder active range of motion, and passive. And then the Codmans was like what he did with Gradon, and with the swinging, the pendulum swings. And then the pulleys, and then the cane exercises. I feel like I'm just repeating everything you just
It's okay. That's part of why I kind of wanted to go first, is so you guys can see if you have about 10 to 15 exercises for the shoulder, you can almost treat any issue with the shoulder. Okay? And so you just, it can seem kind of daunting at first, but when you start looking at it, you're like, oh, this is basically the same thing I've already done, right? Keep going. You're good.
Okay. All right. So it said you could use some gentle shoulder mobility. So kind of like what we did with Tony when Tony came in from Three Rivers. We did hand gripping. And so like the hand grip that Britt showed us. So I know when my mother-in-law had this done, second day surgery, like she loved to crochet. So she went home and she just crocheted, and it was just this movement, just this subtle movement of back and forth. She knits like all the time.
And as long as they're not bearing any weight with anything, the crochet needles aren't heavy enough. And
Right.
the only thing you would have to watch with like crocheting is they're not doing a like big blanket, because then they're having to hold up, and it might actually put some extra pressure on it.
It was a
So
big
those are-
blanket.
So those are just things you want to think about, even as you talk to your patient. Go, well, wait a second, is it really heavy what you're going to be working with? Is it something that's going to kind of pull on that? Because you don't, want to do that.
Right. Elbow, forearm, and wrist active range of motions. So just since you're not doing a whole lot of this, like right out of surgery, you're kind of strengthening everything else around it and keeping everything else mobile. So cervical spine and scapula active range of motion, postural exercises, or I just assumed they were just ab exercises and just structural exercises to kind of keep you moving. And then I found one that said cardio fitness. So just no running and jumping, so you're not pulling on that shoulder. You're just staying active. So I think they had stationary bike and maybe it was just stationary bike and just walking. Just
That's-
light cardio.
And that's good. It is. It's stationary bike. And so sometimes you'll see them come in, and you're just working everything around and then making sure that they're staying fit, since they can't do as much. And so you will have them just ride a bike for 10 or 15 minutes just to kind of keep their body.
Yeah, so for phase 2 was 4 to 5 weeks. And so active range of motion in all planes, gentle shoulder moves, rotator cuff strengthening, which is everything that we just went over in all different ranges, internal, external rotations. It said non-provocative positions, so 45-degree abduction, so I'm sure that's just slight little, instead of full extension, because I'm sure they don't have all the strength to.
Right, because the supraspinatus, right, is still going to be inflamed, and so you don't want to get into you can do shoulder strengthening, but you just want to limit any of the ones that are going to actually inflame or bother the supraspinatus. You especially want to watch
what's the one that actually causes impingement, like scaption or abduction with the thumb turned in? You can actually feel it. Like if you go, everybody try real quick. Okay, go up with the thumb towards you. Now go back down. Now turn your thumb in and bring it up. Okay, you shouldn't be able to get as far, and you'll actually start to feel a lot of pain. What's happening is that greater tubercle has rotated around and is hitting the acromion, and that's actually where the supraspinatus slides in there. And so you can like literally cause tearing just by doing that action. So you'll see supraspinatus tears a lot in people who do the butterfly stroke, because they used to teach them to do the butterfly like this, and it was a constant. They were literally rotating that in and tearing it. So.
Alright, and then same thing, postural exercises for strengthening and cardio fitness, still no running or jumping. For phase 3 was 7 to 8 weeks post-op. So now you're getting into the multi-plane range of motions, and so same thing like with the ball exercises, I guess, is where I would bring in more stuff and do.
So let's have somebody volunteer. And
Okay. Thanks, Taylor. Okay, so for multi-plane direction, what we're going to be doing is I'm going to have you stand here, and we're going to walk up the ball, or I guess you can push the ball. Back down. Have you started? Lean in and stretch. And then, I guess I thought like to do circles. You could do circles for therapy. and
Sure.
just, I'm kind of weak in this part.
no, it's okay. And part of Therex really is a little bit winging it, where you go, well, wait a second, what phase are they at? What are they allowed to do, and what could I do that would be a little different? You could get into start doing like some throwing, okay? We don't have the stuff, I wish we did, but you could start doing plyometrics with them, where you're doing multiple actions at the same time. If you look at your book and look at plyometrics, like you can have a patient stand on like the Bosu ball or something while they're bouncing, bouncing like off of a trampoline and stuff. So you're getting all these more functional activities. They're working on balance. They're also having to throw and extend and stabilize all of that as they're doing it. Once you get into that higher level kind of stuff, they call those plyometric exercises.
So I guess in this stage, since we're in stage 3, we would do rotator cuff strengthening at 90. And so just, Taylor, you want to come in? Yeah. Try to start somebody off at 2. So what I'm going to have to do is pinky up. Trevor's going to have just here. And just as far as up.
Good. So why is she having her do it pinky up?
Internal rotation.
It is internal rotation, but if you do pinky up, you are actually isolating that supraspinatus, just so you know. Especially if you take it and put it into a little bit of scaption, to where you've got that empty can position from the empty can test. You have them go up to 90 degrees. That is totally isolating just the supraspinatus. Okay? So the only thing with that is don't let them go up above 90 degrees though, because they're going to get into where they're, right, they're going to get into that impingement range, and you don't want to have them do that. So if that had been too hard for her, what could you have done?
Or just Saturday, just
Yeah, just try it without the weight. Sure.
and then
In situations like that, though, could you say 2 pounds is too heavy, but 1 pound she could do?
Right, and you might just go, well, 1 pound would be, you
So
know,
it's not always like taking away the weight, you may just decrease the weight.
right.
So I guess I like to strengthen both sides at the same time, and so
No, No, that's good. I always had people do both sides. Just did.
Okay, so, we don't have a plate weight in here, but I would use a plate weight. So I'll give you a 4. So we'll advance you a little bit, baby steps. I guess a plate weight makes more sense because it's like the car. So you bring up, you drive the car. Okay. And it's just a little bit of a combination of those. So still strengthening the rotating hips and the shoulders.
So you're getting internal, external rotation, flexion and extension that you're controlling, and you're actually getting a little bit of scapular stabilization too as they try and hold that.
I'm trying to think of exercises that nobody else has covered to kind of give it
Yeah.
a little
No, that's good. That's part of why I wanted you guys to kind of look online too and find just a couple, 1 or 2 that are different, so that everybody kind of sees a few exercises that they were like, oh, I hadn't thought of that. Like that one, I've never seen that one before. I never thought of it. And that's
usually
really,
see the boys pick up when they go like 45-pound plate. I like to do it with like 25, but like just add it to the shoulders, top them off. Okay, so I guess all these exercises, like I would just show people how to do them. I guess in my head, like everything I would do in a clinic, I would try and teach to where they can do them at home. Because everything I kind of did today could be something that they could do at home. If they don't have a ball, they can get a towel, push a towel up against the wall, and do the towel. The same thing, like we did the cane exercises. I think you can yeah. So same thing. This come out. I guess you can stretch. You can get it in the stretch. So most people have a broom, and I guess just kind of modify to what they have available to them at home.
and those are called wand exercises in general. Just,
Oh, I call them a cane. I think some people. I think a rope cane.
it's okay, because most people end up using a cane, but they call them wand exercises just in general. I just want you to know that, because if you see wand exercises at some point, I don't want you to go, we didn't learn wand exercises. Cane exercises, people use a broomstick, a pool cue, I've seen all kinds of different things, but concept is still the same.
And I guess with just stretches, I just said stretch everything, the neck, everything that's gonna get tight.
The other thing that you really want to be aware of is usually what one of the big things that causes impingement is that rounded shoulders. So you definitely want to do pec stretches because they decompress. And what's going on in the decompression is they're literally just shaving off and reshaping part of the acromion. So just kind of know and understand that. They're going in and they're shaving that off. Sometimes they're removing a little bit of stuff that maybe has built up on the supraspinatus as well, and kind of just cleaning everything up in there. But they'll still have the underlying postural problems and issues too. So we just want to make sure you're strengthening core, strengthening rhomboids, middle traps, and stretching everything kind of out to where they're getting that good posture. They might have forward head and neck too. Okay. Any questions? Good. All right. So what's next? Adhesive capsulitis, frozen shoulder.
Alright, for adhesive capsulitis, or also known as frozen shoulder, it's the thickening of the glenohumeral joint capsule in response of inflammation. So it's characterized by pain and significant loss of range of motion in the shoulder. It affects mainly someone with 40 to 70 years old and females, and mainly with diabetes or thyroid problems. It can be classified with primary, which is like idiopathic or unknown from unknown reasons, or secondary, which is from diseases. So phases, or the stages, phase 1, which is also called the freezing stage, can last to 10 to 36 weeks. During this stage, it presents with intense pain and even during the rest. Right. For our intervention plan for this one, what we can do is like control pain, pain-free passive range of motion, so we can use pendulum swing. Yeah, should be known right now. We can also consider taking maybe medications before doing the stretches, and also ice after massage, after the stretch. Phase 2, which is also the frozen stage, which can last to 4 to 12 months. The pain is decreasing or decreasing, or there's only pain during movement, so we can use active assistive active range of motion. So it's only based on their response. If they're having pain, we can go how much you can do for them. So for these exercises, we're mainly exercising the internal rotation, external rotation, abduction, and flexion. So for this one, we can use the pulley system, the one exercises, just like that, and yeah. For the phase 3, which is also the thawing stage, patients gradually regaining their range of motion, and they're gaining more movement, and they're slowly healing by this stage. So what we can do for just this stage is like increasing the range of motion, strengthening, so we can use weights and therapy band, and mainly that. So for this one, if I heard it right, for this injury, we want them to move as soon as possible. That's right.
For the most part, in the first phase, you have to be kind of careful. You don't want to overdo it, and I'll explain a little bit more as we go. But you just want to be careful in that first phase that you don't try and get them to do overly too much, because it can actually take it and make it worse. This is a really strange one in the fact that they're getting inflammation that is not going to go away, and so the phase 1 literally can last almost a year. Like it can last months as that inflammation and tightening starts to happen in that shoulder. And so it's weird, because you would think, oh well, it's starting to tighten up, I want to get it moving. But if you overdo stuff with it in that initial stage, it'll actually make the whole process longer. And so this is a weird one. We'll talk about it a little bit more, but I don't want to interrupt. Okay.
So the exercise that we were taught. So yeah.
Good. So what you guys can do is kind of go on, look them online, and just find some new and different exercises. But like I said, I did intentionally do a vast majority of them just so that you guys could kind of see them, and then we could see how they apply across the board to all these different scenarios. And so literally, if you learn 10 or 15 different shoulder exercises, you will be able to treat somebody almost no matter what. And then you just understand that everybody, with the exception of things like scapular winging, there's not really phases in that, but you still know how to treat it, and you know the exercises. The rest of them, you understand that they're going to go through this phase of inflammation, kind of just recovery and getting motion back, and then strengthening and functionality. And so that's kind of why we're doing this, is so you guys kind of have a quick review of what it really is, and then start to understand how to treat it. Which, if I had my preference, the notes, the Canvas notes would be just one of these for each thing. And so you would have, this is what it is, this is how you treat it, these are the phases for it, and these are some exercises that you can do. Okay? But I'm gonna actually use these in time, and I'm gonna make it that way. But that wasn't what it is, and so we're doing it this way. But that's good. So the thing with frozen shoulder is there's two different types, right? There's primary, which is they don't know exactly what caused it. And it's called idiopathic. It just starts, the body just starts kind of freezing up literally, and it usually almost always happens in the shoulder. It can happen technically in other joints, but it's mostly always in the shoulder. It's of unknown origin. They don't really know why. It is more common in people with diabetes, and it's way, 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 way more common in women. It rarely happens to men. And it usually is from the age of 40 to 60. And what'll happen is and there's 3, or sometimes depending on who you talk to, they can say there's a 4th stage. But in that first stage, the freezing stage, they'll just start getting pain in their shoulder all the time. And they really don't know why, and they don't know what's going on, and it just hurts. And it doesn't, they're starting to maybe have some problems with external rotation, right? And possibly even with internal rotation, and sometimes with abduction. But generally, they still move fairly good, okay? But then all of a sudden they move anywhere from like 4 to almost, I think 10 months is what the book said, 4 weeks to 10 months. That first phase can be going on. And it just can be getting worse and worse and worse. And then eventually they hit this stage where it's called frozen. And then you're not able to move the arm at all, basically. It just kind of, so the pain basically stops, right? And so it's not that they hurt anymore, but that the adhesions and the hardening of the joint capsule have become so bad that they just really can't move. And so this is the stage that you can start really stretching them even more. You can do light stretches in the first one. You can stretch them for like 15 to 30 seconds. And you would send them home and have them do active and active assistive range of motion and things like that in that first phase. But you just have to be careful that you're not increasing pain, and not increasing because it'll make it last longer. It'll make the process last longer. Once it stops hurting, then you can kind of get after it a little more, and you're moving into, you can do closed chain isometric exercises. You can do more stretching, and then in the thawing stage, that's basically that final recovery stage where you can really start stretching them hard, start doing PNF stretches, start doing PNF patterns, and really try and have to stretch it. But the whole process can take 2 years or more sometimes. So just kind of understand that. It's a really interesting one, and I would recommend, you can either look at this, the Colby Kisner on it, or I actually like the,
What's the time frame for stage 2?
So stage 2 is basically usually from 10 months to up to like 18 months to almost 2 years, and then that final stage, usually after 2 years is when you start entering that thawing stage, and you can start really getting them moving and up and going. But it's really kind of a weird thing and a mess. The second type, just so you know, is like sometimes the same thing will happen, but with people who've had surgery. And so you have to really watch people who've had like subacromial decompression, or people who've had a shoulder replacement and things like that. They have to hold their arm still for so long that the capsule just starts to tighten up and cause the same problem. And it can go through that same process where it'll take them 2 years to really, but mostly when you see it, it's idiopathic, and people with diabetes for some reason seem to have it more.
What modalities?
Well, in that initial stage, you would be looking more at cryo, but they, from my understanding, I'm trying to remember, they don't do as much modalities on it, but later on, you'll get into like ultrasound and heating and stuff to warm up for stretching and things like that once you've moved out of that initial phase. Any other questions over that? It's a bit of a strange one, and I'll maybe add a few things here and there on that one before I turn it back to you guys.
Is the test based off of the Canvas notes, or?
The tests are going to be literally off of either the Canvas notes or the book, and I will have told you what page numbers to look in the book. So for this next test, like I'm not going to guarantee there are no mistakes, because as much as I want that, every time I think I've gone through a test good enough, like somebody always finds one or two. But this last test, like I spent days and days and days, not on this one, but on the one that we're about to take in a week or two, I literally worked a lot on that test. And so the main thing is just the study guide will guide you exactly where you need to go as to where the questions will be from. But most of them will be actually from the book or from Canvas Note. Okay, these are more going to be to help you to get ready for the practical, because in the practical what will happen is you'll come in, and if you look at your examples, it will say you have a patient with this condition and they're at this stage. Basically they're 3 weeks out from a knee replacement, or obviously it wouldn't be knee replacement, but a total shoulder replacement, or 3 weeks out from a subacromial decompression, and they're coming to you. What would you do? And you need to be able to go, I know what I would do. I would do these different exercises. I know what basically stage they're at. I would be treating them with heat, and so it's taking some of the pieces from 150 and starting to put them together with the exercise things that we've learned and are learning today. Okay? Make sense? I won't leave you guys just floating out there, because I know the notes aren't great. But that's why I went so carefully through this test, and I hope there's no mistakes. But I really went through it like a lot. And so between that and the study guide, you guys should be good. And there is a Kahoot too. Okay. All right. So up next is biceps tendonitis. Is that right?
You're going in the order, module 8, right?
Yep.
Alright, so for bicep tendonitis, and the notes I've actually given for it was actually more proximal, but it could be either one, because there's two different tendons. So basically, this inflammation right here on the top of the shoulder, right here where that tendon is, and there's 3 different types. So the first grade would actually be, is basically a mild strain. There's not really much tearing there. They still have full momentum, so there isn't really much of a precaution there. Just think they can still exercising, not exercising, still strengthen it, they still stretch it, but not to the full extent. And then the grade 2 is a strain that is, or there is still tearing within the muscle, and there is decreased motion in there, but we still wouldn't want to put full strengthening or full stretching in this stage. And then 3rd grade would be a complete rupture of the tendon. Alright. And so for the first stage, you would mainly want to, after they have their surgery, after that first week, you wouldn't want them to put any weight bearing on the arm. So if they weightlift, or if they do gymnastics, or if they like to work out, they wouldn't be able to do that for that first week. And then afterwards, you would probably put a lot of modalities on that, try to ice it, try to reduce inflammation, and slowly, passively stretch that arm. And then afterwards, when it does strengthen, you can try to do different exercises, like with the resistant bands, try to do some flexion here and there, and try to work with that. Also with PNF too, kind of needs to work with that. On the different exercises, again, like you guys were talking about the shoulders.
So let's see you do a PNF with a TheraBand.
Okay.
So we need a volunteer.
Thank you, Katie. So great. Okay. So I'm going to go ahead and do this motion. So okay. So we go ahead and do so I'm basically going to explain to her that the different range of motions that we're going to do. So this is a combination of the different shoulder movements that are included in pattern of D2, with external rotation, internal rotation, flexion, and extension. You could also do different patterns of PNF two, with D1. You could also do PNF stretching, like isometric stretching, for instance. I know I'm just going on this right now, but we're going to focus on this one before we go to the other ones. Yeah, so I would hold it from right here as she's doing the motions right there. And then she would go back down. Okay. And then in this stage, you can also have her do isometric. So put her right here. Okay. So what we're trying to do, Katie, you're basically going to try to go up while I'm trying to push down on you.
Okay.
And try to hold that position, okay? Alright, and this one actually will help strengthen this shoulder joint right up here. Right here. Okay. And you can also do elbow flexion too, this way, as I am also holding her back while she's trying to do a simple curl. Okay. And then the last stage, you can also try to do different strengthening exercises, like using a dumbbell and having her do a bicep curl, and then also doing a shoulder raise that way. And then for home exercise programs, definitely have them stretch, do the little walk-ins with the wall there. And then I like this other stretch that you do with a towel. So Katie, I'm gonna have you stand up for this exercise, and you can actually face the other way. Okay, so this arm. So what we're gonna, okay, I'll move out this way first. So what you're gonna do is you're gonna take this towel and you're gonna put it behind you like this, and then just slowly pull it back. And this stretch will help the shoulder.
Pulling it down.
Good. So yeah, you can do shoulder stretch both directions. This is going to stretch the, right, one's going to stretch internal rotation, the other's going to kind of stretch more the back half of the arm here and into the tricep and things like that.
And then, so there's also one more exercise you can have them do. And they can do this seating or standing, depending on the preference. So what you're gonna do. So I was doing this last night, and it was actually pretty hard. So you hold the cane. Yeah, you hold the cane like this, and then you're basically trying to raise it. And so they say this one's my affected arm, and you're basically using much most momentum in this one, and you want to make sure your thumb is up when you're doing this, and try to assist you as you raise that arm. Okay, want to try that?
Like this?
Yeah.
So is that kind of like a PNF too?
It has a little bit of a PNF because you're kind of getting that, but they're really focused on strengthening that long head of biceps brachii as you get that shoulder flexion.
And then as they continue to strengthen up their shoulder muscles, then they can be able to go back into full activity. However, proper strength stretching should be done before and afterwards, as well as heating, or not heating, but icing that limb, just so there's no osteoarthritis afterwards and re-injury. That's it. Nothing else?
So with biceps tendonitis, it just kind of depends. You know, if they're stage 1 or 2, the first stage is still the same. You're kind of resting it, you're icing it, you're trying to get the inflammation down. You're going to do like isometrics to kind of still keep strengthening. You're going to strengthen the joints around it. And then once they've kind of moved out of the pain and the inflammation phase, then you're starting to do range of motion with them. And then you're kind of start doing strengthening. The thing that differs it from the rest of the shoulder, though, is biceps is affected by the elbow as well. And so you're going to add some elbow flexion and extension strengthening exercises in there with it. If it's a stage 3, though, there's a good chance that they'll have to surgically repair it. And if it's surgically repaired, then it just expands that process. Instead of a week or two of stage 1. You might be looking at a week to 4 or 5 weeks of stage 1 as they recover from the surgical repair, and then but the rest is still the same process. Okay, now that they're able to start moving and they're pain free, we're going active assistive range of motion, maybe some light strengthening in that first phase. What do you guys know the other term for isometrics? Have you come across it in your reading? It's also called muscle setting, just so you know that. Okay, and that'll actually be something that you'll see on the test, just so you know. It's on your study guide, and I mentioned it, but on your second test, just know that muscle setting is just another term for isometric strengthening. It's a way to try and strengthen the muscles around a joint without actually moving the joint, and so they call it muscle setting. So you're trying to kind of stabilize that joint without having to actually move the joint. So that's why isometrics are really, really good in that initial stage or at level 1 strength, because it allows you to still get strengthening that joint without having to move it at all and increase inflammation or anything like that. Okay? All right. So any questions over that? Humerus fracture, we already had that one. You do that, you're welcome. So who had shoulder impingement? You're going to find this one really, really similar to rotator cuff tear and subacromial decompression. But this is before those things have to happen. And so sometimes we can get somebody and fix them, right, before they have to go do those other things.
Yes, so shoulder impingement happens when the acromioclavicular joint impinges on the supraspinatus muscle. So in phase 1, your goals are to minimize pain and swelling, and you can use full passive range of motion. Some exercises that you can do are chin tucks, scapular retractions.
So
for scapular
show
retractions,
us chin tuck, because that hasn't come up yet.
so
So we need a patient. We need a patient.
I don't know how to do this.
Show us chin.
I guess you're sitting straight up, and you just want to kind of tuck your chin in, like that, and hold it.
And then pull back a little bit too. No, you're right. It's just, so chin tucks is you have them kind of bring their chin just down a little bit and then pull back. Okay, and so it's really to bring the head back, and it's strengthening of the suboccipitals. Okay, so they're kind of just bringing. They don't have to bring it all the way down. It's just kind of tuck it just a little bit and then pull back. You can have them pull back and hold, or you can have them just do it repeatedly. Okay, but that's how you. So it's just kind of a gentle tuck of the chin, and then pull back that head and hold it. Pull back that head and hold it.
To add to that, couldn't you put them like up against the wall with a ball and like have them
You can.
into the ball?
You can have them do it with a ball. Another way you can do it if they're very early on into the process is
What? More cheese than Chinese food.
just have them do it with a pillow, right? So have them lay down, and I don't want to grab a pillowcase, so I'm just going to put this over it real quick. Just have them lay down with their head here, okay? And while they're laying down, they can put their head here, tuck their chin, and push down into the pillow. Either have them hold it isometrically, okay, or just have them do it over and over to where they're starting to kind of strengthen those suboccipitals. So if they're having a harder time doing it sitting up or like against the wall, then you can do this, and this is with gravity assistance, right? And so this is like the very early stages of that. So people who've been in bed for a long time who just can't hold their head up at all, They got really forward head and shoulders. This is a really good exercise for it. Sorry.
You could also do scapular retraction.
Sorry.
And that's just basically bringing your scapula together like this. You could also bring your arms up like this and bring your scapulas together. Squeezing them together. You could do manual therapy, so soft tissue massage, glides, and joint mobilizations. You can use modalities as needed, but ultrasound is not recommended in the phase 1.
Why wouldn't it be? Right, because it's heat and you're just going to increase that inflammation. Could do it.
In phase 2 treatment, your goals are to increase scapular strength. It also says RTC, is that rotator cuff?
Rotator cuff, yeah. RTC is rotator cuff.
And flexibility and proprioception, decrease pain, and maintain range of motion. So you could begin with active assisted range of motion and increase to active range of motion. And then you can begin with scapular exercises and progress to rotator cuff exercises. So you can use a TheraBand and do rows, extensions, internal and external rotations. You could do the serratus punches, which you can.
All right, let's get another volunteer. If you haven't gone yet, then we might have to rotate people too.
I would just lay down on that table here. And just straight up. And then just bring your shoulder. You can do one at a time, or at the same time, and just bring your shoulder straight up.
Good. So if she wasn't able to do that, what could you do?
Just.
You could try it without weights, but if maybe she still couldn't. What could you do?
You could put them,
Yeah, have them sit up.
you could even put them on the table to take away all of her.
Good. You have them just sit at a table and have them start kind of doing it here. Yeah. So that's the only other thing that's the only other piece that you guys need to be aware of is just to be able to any of these exercises either know how to regress it and progress that specific exercise, or at least know an option to go, well, you can't really regress that exercise, but here's an exercise you could do instead. Okay? But good, that's a good exercise.
And then you just, you could do seated press-ups, wall push-ups, sideline external and internal rotation. You can begin rhythmic stabilization in phase 2, and then continue stretching and manual therapy as needed. For phase 3, you do resisted exercises. Your goals are to increase rotator cuff and core strength, and maintain flexibility. The exercises that you could do are PNF, upper extremity. You can advance with rhythmic stabilization. You could do quadruped exercises. So quadruped exercise would be if she were to get on her hands and knees, and then I would ask her to, let's say, raise this shoulder, and then you would raise your right leg.
These are super advanced, just so you know. This is pretty high level quadruped exercises, but they are also very good because what's going on is you're stabilizing while you're also strengthening. And if they get really good at it, you can add ankle weights to both arms and hands or dumbbells. But they're really, really good exercises for honestly almost just about anything, because you're strengthening your core, you're stabilizing your core, you're having to kick in shoulders. You can have them start with just the arm, okay, and then you can start trying to add a leg and things like that. Those are great.
And then you could also use stair stepper or the treadmill with upper extremities. Basically anything with sports or work specific exercises. The type of stretching they might do, one is called a sleeper, so you lay on your side. And then, like with this arm, out like this, and then you would do kind of like a internal rotation. And stretching like that.
Good. And that is a sleeper stretch. It's a common stretch that they do for internal rotation. The only thing you kind of have to watch is make sure they're not positioned to where they're really laying directly on top of the shoulder. They should be a little bit kind of, just a little bit back to where they're more on the scapula, and so that they have a little bit better range of motion in that. Does that make sense?
Do the towel internal rotation stretch, which is pretty much the one we've been doing.
Yeah, and the key with that one is just make sure that that bottom hand is with thumb up, because people will try and do crazy stuff. Like you're like, oh no, and you're like, why does that hurt so much? And you're like, well,
We can start like by pulling it this way first, and then if
yes. Right, good. That's good. That's a good point. You can start, and this is why we're doing this all together, because you guys will read and you'll find stuff. If they aren't able to do a full rotation like this, you can start them with just here, and then having kind of pull back and starting to internally rotate it, starting to kind of come across, and then as they get a little bit better, you can also have them go more into this, where it's even more of an internal rotation. Good.
You're stretching the upper trapezius and posterior capsule. You could do a corner stretch and upper thoracic extension. So the home exercises in phase 1, you would instruct in activity modifications. You want to limit overhead activity and keep shoulder below 90 degrees. You want to do postural education, exercise instruction. In phase 2, you want to continue phase 1 instructions. You can do pulleys, and they can do cane exercises. In phase 3, you want to continue all the exercises we went through, and just add the sports or related work specific exercises.
So the one thing that we haven't touched on too much is once you get people into that phase 3, one thing you want to do is to adapt it to where it's going to relate to what they do day to day. And so you want to start going, well, show me what kind of actions you're doing at work. Like if they're a postman and they're constantly having to lift and put things up as they're sorting mail to get it to go out, and then they're, and so you want to start thinking about ways to take it and make it specific to them, to where their strengthening is a little bit more functional. If it's a grandma and you've improved her shoulder range of motion, then you might literally have her, do activities that are going to keep that range of motion, like brushing her hair or reaching up to put cups away. And so you might take like these cones, okay, and go, well, you were having problems with putting your dishes away. We don't want to send you home until you're strong enough to able to do that. So you might take these cones and just have her place them up on something high, or where you even stand. Let's stand up. You go, okay, so you would just kind of say, hey, I want you to kind of hand those to me, and you would have grandma, take them and reach up as high as she can. And so you might even like put like a 2-pound ankle weight on her wrist, and then have her move in all different directions and make sure that she's keeping proper posture and moving correctly, so that you're moving into more like day-to-day functional strengthening and movement. Okay. That was good. So do you guys understand what's going on with shoulder impingement? Instead, it's getting trapped under there. Usually, almost always, it's caused by bad posture, actually. That's where strengthening, once again, those rhomboids, middle traps, and stretching the pec and doing the chin tucks to kind of pull the head back too. Because if this gets tightened forward, guess what your trapezius is going to naturally want to do? Well, think about it. If your head, so your trapezius is one big muscle. It's all attached together, right? So it starts here, attaches here, goes all the way down the back. So if this part of it starts going forward and staying forward all the time, what's the rest going to naturally do? It's going to kind of come forward too. It's just going to naturally pull it forward. So sometimes, and she did really a good job of going, it starts here. Because we're not just going to fix here. If we don't fix here, it's still going to end up pulling them forward. And so somebody who had impingement syndrome and was starting to have pain in that supraspinatus, if we don't fix all the postural conditions that cause it, they're just going to end up right back in there, and then they're going to end up with needing to get subacromial decompression, or even worse, a rotator cuff tear.
How do you diagnose it?
How do you diagnose? Well, there are actually tests. What's the test for impingement?
Hawkins.
Oh, Hawkins Kennedy. This one?
Hawkins Kennedy is one of the ones for it, and no, Open Can is for tear, isn't it? Actually. Okay, but Hawkins Kennedy is the one for impingement. Okay, and so that is the way you can kind of test for it if you started to get that impingement, but then you can fix it.
So they present with just pain and loss of range
Yeah,
of motion?
they'll present with pain and swelling and loss of range of motion, usually right in here, sometimes down into the top of the shoulder here, because the whole thing gets inflamed. And if you catch it soon enough, you can deal with it before they have to do the other stuff. Now, sometimes subacromial decompression, it literally is like there are acromions not shaped right, and so you can't fix that. They'll have to go in and repair it. But usually, both of those actually start with this, okay, with the supraspinatus tendon inflammation and impingement syndrome.
So does the acromion, does it like develop bone spurs?
Well, it can develop growths. What also can happen is you got that bad posture, and then the supraspinatus, as it moves along it, slides along it, will start to kind of tear, and it'll start to, even the supraspinatus can start to build up kind of some growths and stuff on it, and because it's trying to constantly repair itself basically, and so they'll have to go in and shave the acromion, and sometimes they even remove.
I saw where they disconnected, like where they could cut the biceps tendon because of the tightness that it all causes.
Right. And so there are some other things, and so this is where actually things get really interesting, because our body is all tied together, right? And so it's just amazing to think that somebody who spends all day reading all of a sudden gets this, and then they get shoulder impingement, and then they get, they either need a decompression or a rotator cuff, and if their rotator cuff goes bad and they still continue to do something, it starts to damage the joint itself, and they have to get a whole total shoulder replacement, when if somebody had caught them soon enough and known what was going on with some stretching and some strengthening and a little bit of rest and education on posture and things like that, they wouldn't have had to go through that whole entire process.
So if impingement can start with bad posture, can you use the foam rollers?
Without a doubt,
Would that be like phase 2?
Well, no, honestly, for stretching with that, so she's talking about the foam roller stretching that I asked about the other day. for the pec stretch. You can go ahead and do a foam roller stretch in phase 1 of impingement syndrome because you're not doing anything that's actually affecting that inflamed part, are you?
Oh, yeah.
You're not stretching that muscle, you're stretching the opposite muscle. So it's one of the weird exceptions where you can actually start doing some stretching, but you just want to be careful. A foam roller would probably be better because you don't want to be putting direct pressure on the whole shoulder joint because of the inflammation. Good? All right. Is this starting to kind of come together a little bit for you guys? Okay, good. All right. That was my hope, is that as we did it, it would start. So.
We talked so much about impingement and there's literally one line.
Right.
Crazy.
So instability, subluxation, dislocation. So who had anterior shoulder dislocation? All right, you're up.
You okay, Katie? Yeah. Do you need lunch break?
We're almost at lunch break.
Yeah, you gotta speed it up.
No, do a good job. Gosh. Kids today.
So I had shoulder dislocation repair, anterior. What a dislocation is, it's just the humeral head coming out of the glenoid fossa, pops out. You may have seen it before. Somebody falls or something, and their shoulder's like visibly like lower, or it just looks nasty. So that's the dislocation. A subluxation is the partial humeral head coming out, so it's not completely torn away. So the dislocation is it's completely torn away. Instability, that's due to hypermobility of the shoulder. So that's not big too, because it makes it kind of not too stable.
It usually starts, just so you know, usually unless there's a cause for the dislocation, like they fell, people can still get dislocation. It just gets weaker and weaker over time. So it starts with instability, moves to subluxation, and then eventually just kind of pops out. Did you read how often it's anterior versus some other kind?
It's more than it's more.
It's like
anterior.
98% or something of dislocations are anterior shoulder
So they're coming
dislocations.
this way?
Yeah, it pops forward out just because that's actually the weakest part of the joint and it has the least protection and least stuff to hold it there. It can be inferior and it can be posterior, but that's super rare.
Yeah, so they can have it like multi-directional, and then you can visibly see it. The diagnosis for it, just by physical examination. If they're any unconcerned or they're not sure, they can use an MRI or CT with some dye, and then you can see that it's messed up. So that goes into it came with like a phase 0. I found.
Some of them do actually have like a phase 0, like before you do anything, and sometimes we'll even consider phase 0 as pre-surgery.
Yeah, so for mine, phase 0 is 0 to 2 weeks after surgery. The goals be controlling the pain and swelling with ice, protecting the repair, so they're in a sling at this time, and then they begin early shoulder motion. So the treatment for that is just, since they're in a sling, you want to get them not like having contractures in their elbow. So the main thing is to do pendulum exercises, which we all saw, just leaning over and having them move it back and forth. It's kind of more towards like the second week, because the first week I guess it's really doesn't feel good for the patient, but they can tolerate it, I guess, is what I read. The contraindications for that is external rotation and abduction, so you don't want them to be long like that, I guess. Is the
Right.
main thing. So that was the big thing, and then excessive shoulder extension. So that's phase 0, and then
I'm going to pause just for a second. No, I just don't want to interrupt you. I don't want to break your flow. So the big contraindications for anterior capsule repair with a dislocation are what external rotation, extension, and what was the other one?
It just says external rotation and abduction.
No, there's one. It's external rotation, internal rotation, and I think horizontal abduction. I believe. Just to kind of throw that out there. Why would that be?
Because it would make that joint come forward.
Right. That's where, if you think about where your shoulder moves, it's pushing that whole that humeral head forward in that glenohumeral joint. Okay, so any of those ones extension, your shoulder comes forward, right, and you can literally feel it. Flexion, it can also as well a little bit. So just kind of know that.
Yeah. So phase 1 is 2 to 5 weeks after the surgery. Main goals for that is to protect the repair again. So they're still in a sling. Ensure that the wound is healing. So just double checking, make sure that it's, like the surgery that they have done isn't infected or anything. And then prevent shoulder stiffness. So they're still in a sling. Contraindications are basically the same. They can use the arm just without rotation. The doctor can tell them, you can take your sling off for a while, whatever, keep it in there. Stretching and a passive motion they want to do 7 days a week, 4 times a day. There's a lot of exercises you can do. There's the pendulum exercises, supine external rotation. You're just laying down, and then you have your arm kind of like on a towel. You start here and you just kind of go there, but you don't want to go past 0 degrees.
Good.
For the first 2 weeks. Progressing from that, you can go from weeks 3 to 6, go up to 30 degrees. And then after the 3rd week, you can start doing behind the back internal rotations. So with the towel thing, it's kind of where you're showing. And then you can go into strengthening exercises, which would be isometric exercises. So the same thing with the ball. You take the ball and you just put it against the wall and you just hold it against there, back and forth. I seen one with a towel too.
You can do it with a towel as well. You can do a towel either against the wall or obviously you can put it underneath your arm for abduction as well.
I've seen too, Brent, where they'll put a belt around the hands with a ball, and then they'll have them push out against the belt and then push into the ball
right.
this.
Yeah.
So you could go both direct, or I guess a TheraBand around the wrist, or.
That's good. I haven't actually ever seen that one. And so yeah, so it's just another way to kind of squeeze. You can squeeze a ball in. You can go in and out as well.
So some other exercises, strengthening exercises, would be a prone row. So what you would do is you'd lay down, and then you just bring your arm back like that. But you don't want to go too far back. You just kind of to here. And then they have prone extensions, but you don't want to go past the hip at this point. So that's, instead of having it at a 90-degree angle right there, you just have your arm back and then just come up to here while you're laying face down.
Caleb, are you doing in like this, or are you coming out like this? So you're staying in? Okay.
Well, so.
Yeah, yeah. I was gonna say let's demonstrate these.
Like
so
this?
somebody come help. Somebody come help. So he can be the instructor.
Watch on you.
Because I want you guys, and we're gonna practice all of these. So but I want you guys to kind of see.
So then she's just gonna want to bring her arm up to here,
Okay.
Just like that. She's gonna want to not have any rotation. Try her best not to have any rotation in that. Because she is like this, and then the next one she's just bringing her arm back to here, just to her hip, just like that.
So what's the resistance with these?
Grab.
Yeah, just gravity. Okay.
Okay, I'll stay here.
Then she can do side-lying external rotations. So you can lay to the side. This is like those old home movies where it's 90, and you're just gonna go like that. So just external out. Yeah, not too far. Just kind of to what they're tolerated to, I guess.
Well, and I
it's
think
kind
at
of the
this,
same thing
I think
for
at
the
this
degrees.
stage, are we still at 60?
Yeah, they can
Yeah.
move up to 60. So, and then rhythmic stabilization and proprioceptive training. So same thing we've been going over, you can kind of push their arm, depending on what exercise you're doing, you kind of push your arm back and forth, making them hold in place, I guess, or
And what are those called? Alternating isometrics. Yeah.
so, and then ball squeeze exercise. So this, I guess this is more for like your arm because it's in a sling. Because so you're gonna take the ball, and you're just gonna squeeze it.
Right. So as you're you just want to make sure we're still strengthening those muscles around, because they're not going to be using that hand as much because it's going to be in a sling. And with this, like they're in a sling for, somewhere between into months. You're basically in a sling for months after this. Okay.
So this is phase 2, 5 to 8 weeks after surgery, and the main goals for this is to protect the shoulder and avoid overstressing due to repair, improve the range of motion, and begin more strengthening exercises. The sling is at this point could be taken away and they don't need it anymore. They can use.
So you're looking at basically a month to 2 months before they take the sling away from them. Okay.
So you can use your arm now. You just avoid having the arm like forcibly pulled behind you. So I guess if somebody's jerking you around or something. You don't want to do any manual labor or heavy weightlifting still. And then you don't want to lift objects over your head. So if they have like something you need to reach for, they can't. Well, they kind of can, just not enough like with weight, right?
Right. You can start reaching over your head, but you don't want to do any weight just because it can put pressure on that joint capsule, and you just have to have the time for that joint capsule to heal.
So for like stretching again, it's the same thing, pendulum exercises, that supine external rotation, standing external rotation, so you can have the patient stand up and just come out. And then you can increase the amount of degrees for that.
Are you going like to their tolerance, or is there another limit?
You said 60 for last, but it's like 30 to 45 is what I read.
Right.
Down there for
It moves in progressions. I know like the first 2 weeks, and I got him here, but I think he's got them. It's like the first 2 weeks are basically you can externally rotate, but only to 0 degrees. So you would have them go to here, and then 2 to 4 weeks is up to 30, I believe, and then you start moving into that 45 and 60.
So we can introduce supine passive arm elevation. So lay it. So this, she's just gonna wanna like say it's this arm. She's just gonna bring this arm with that. So you're gonna reach over and you're just gonna like bring her up just as far as you can go. Just like that. And that would be that. And then for strengthening exercise,
That's weird.
TheraBand internal and external rotations. So through the door, tie a knot, put it in there, and then you can just internal and external slowly. So the prone rows again, and then prone horizontal abduction tees. This one's, I guess.
Yeah, let's see that one because I don't actually think I know this now.
You're just gonna bring your arms out to the side.
Oh, okay.
Just like that. So what you want to do is limit the extension that she's lying still though, and she might still have some pain in that, but she can do that.
So are you not supposed to go past neutral?
Well, I guess it depends on what the doctor said is what I read.
Right.
So
And so that's the thing that we need to understand with all of these is these are kind of general idea guidelines, but it might change from surgeon to surgeon.
and then same thing, rhythmic stabilization and proprioceptive stuff. So then we move into weeks 4, or was that 3?
I think that was 3. Wasn't it?
Yeah,
TheraBand, internal, external
no.
rotation.
Oh, now it's 3.
Now you're
Yeah, so phase 3 is 8 to 12 weeks after the surgery, and the main goals are basically the same: protect the shoulder, regain full range of motion, and continue gentle strengthening. Stretching is the same stuff. They can start doing more things behind them. Behind the back internal rotations, towel can be a little more, a lot more range, or should be more range. This is where you start introducing more resisted things, I guess, for strengthening. So you can start using the TheraBands. So let me have you sign. So what you're gonna do is, this is called a dynamic hug. So you can put it on back. Like you're hugging.
Alright. I'll take it.
Just like that. And then, let's see, you can do like seated rows with these things. We don't have like a stationary thing, but so there'd be like a stationary object or like a pole right here. Yeah, just like that. So,
So you can have them do, that's extension. You can also have them do rows here. And I don't know, it's, rows are one of those things, some people have them keep their elbow kind of here. I was always taught kind of here. So just kind of know that. You can either hold it for them, or like you said, there you can wrap it around something. You can tie a knot in the middle and slam it in a door and do
If you don't
rows.
have a weight rack or something.
Yeah.
there's a standing forward punch, which is, Valerie showed it, but it's standing, just like that. So that would be around the phase 3, and then.
If you were to make that harder, would you just put a weight in there?
Yeah, or you could add one of these.
You would have it behind them, so they're pulling.
Yeah, you would
forward?
have to, yeah.
It'd be like.
Oh, okay.
They use, instead of TheraBands, they use, the things that I've seen they use were those resistance bands, so they're like the tubes.
With a handle.
You've got some right here, just so you know. Like this. They have ones, and they even have these really cool things, just so you guys know, that you can take your TheraBands, run your TheraBand through here, and then tie it on to where you can turn your TheraBands into.
I have no How do I?
Okay, so phase 4, we're getting into weeks 12, or actually grouped phase 4 and 5 because it goes from weeks 12 to 24 and then onward. After the surgery, and the main goals were the same: protect the repair, regain full range of motion, and continuing strengthening until they get back to their full activity. So it's basically all the same exercises. You just add more resistance to those things. And at this point, they should be able to get to like the external rotation of like 90 degrees, internal rotation of 90. They can do standing T's, diagonal up and diagonal down. So like with a cable machine or TheraBand, I don't know how I'm gonna show it, but you just like that.
So what is that? Basically PNF, right?
Yeah.
It's a good way to do that home.
Yeah, and that's a great way to have them do PNF at home. Or you can just have them hold, if they're sitting, and do it here. Hold one end, and then they go here.
And then you get into like really different strength things, and it's like bicep curls you can do, resisted forearm supination, pronation, like regular exercises at this point they can start doing. And then from there onward, you just enhance the. No,
That's it.
Yeah. So this goes on to like after 24 weeks after the surgery, so onward into years. This is the main goals for these is to enhance the muscular strength, power, and endurance, progress functional activities, and maintain the shoulder mobility. Yeah, and you can continue the exercises they've been doing while adding more resistance, but really their shoulders should be kind of good to go. Yeah, and that's pretty much it. The additional things to consider is if you do weight training, you should, or weight training, or you're like an athlete, because this happens to a lot of athletes, younger kids, things like that, playing football mainly, they do have to wait about like 3 to 6 months to actually be 100%, not even 100%, it's still kind of iffy. So, and then there were some exercises that are usually problem-free from that, and that's the biceps curls, table and bent over rowing, and shoulder stretch. So, any questions?
Good. So the thing with this is that you kind of notice that they've even added in some extra phases because it's just a longer, slower process. Because once that shoulder capsule becomes destabilized, it really is hard to get it restabilized, especially if they have to surgically repair it. You might find some people who had one that they manually reset, and just be aware that you might get to work with somebody like that. It's still the same process. It can be a little bit quicker because it wasn't surgically repaired, but you do have to get that strengthened up again, or it'll just keep happening to them. Once it happens to them, the chances of it happening again are actually super high because it usually damages the labrum, and then the labrum really is a lot of what